Welcome back to Medical Monday. We are talking about happy, healthy feet, and if you don't have them, then tonight is the night to call. Dr. Matthew Newhouse is here, a pediatrist in the area with 8 different offices, 8 different locations. It's Newhouse Foot and Ankle. If you're looking for them, you can go ahead and look them up. We're going to give you the number and how to get in contact with them and make an appointment here at the end of the show. So get a paper and pen handy. But as always, we want to get to your call. So Carl is on the line. Carl, thanks for calling in.
Hello.
Hello. Go ahead with your question.
My question is, I wear boots like kangaroo boots are real lightweight, and I noticed over the years so my heels are wearing on the outside on both feet, and just wondering what that might be causing that.
Okay, I'm sure you see a lot of different how we walk. It matters.
It does matter. Yeah. So he's talking about the shoe wearing on the outside of the heel, and that's actually a very common, normal way for the shoe to wear. When we walk, most people have what we call a heel strike. So you hit with your heel, and then your foot rolls forward. You should hit with the outside of your heel and roll in and push off with your big toe. Oh. So the big toe is the big lifting point to give you propulsion and keep going. So it's very normal to wear it on the outside. That's in the outside, or the middle is where we want to see it. If it's wearing on the inside, that's a bigger issue that can cause problems. I would also remind him though that if your shoe is worn like that, you need new shoes, because that will cause a problem. The heel should not be worn. By the time the shoe has the rubber on the heel worn out, the rest of the shoe is shot, and you need new shoes.
So Carl, it's time to go shoe shopping.
Yeah.
That sounds like fun to me. Good luck with that, Carl. Thank you for calling in tonight. Do you see many runners who come in and say, man, I'm not feeling good when I'm running, or what do you hear?
We see a lot of runners.
Yeah,
we treat a lot of runners.
What are the common complaints?
Kind of the same as everybody. You know, they don't come in until it hurts.
Yeah.
And they've tried to treat it. Runners are the worst at trying to treat things. They talk to their other runner friend that had this problem and that problem. We see a lot of stress fractures with runners.
Really?
See a lot of people that are trying to get into running that will develop plantar fasciitis or tendonitis, Achilles tendonitis. Stress fractures are probably the biggest thing we see with runners. The newer runners don't understand how often they need to change shoes. You know, running shoes are very expensive, especially if you get a good pair. And all the good research says you should change your shoes between 300 and 500 miles. Oh. So it's really important to keep a log if you're a serious runner, to know how many miles are on the feet, on the shoes. And the reason for that is the shoes are typically made out of a substance called EVA, which is in the sole, which is a foam that's in the rubber, and that compresses. It has little air pockets, and as you pound and run, those air pockets compress, and then you lose the cushioning that's in the shoe, and you can't really see it. By the time you see the wrinkles in the rubber and the sole, and it's looking old, those air pockets are long since gone, and you've lost the cushioning in that shoe, and that's when you're going to develop a stress fracture or tendonitis, because that shoe's not giving you the support that you need to take that pounding that a runner's going to give it.
I just went through that with shin splints. I went, uh-oh, it's time.
Same thing.
It's beyond time.
We'll see the shin splint problem, and that's a big part of it. Is once you feel that kind of coming on, first thing you should do is change your shoes.
Yeah. Okay. You also have a procedure that you do with a hammer toe. And before we get into the procedure, what is a hammer toe?
Yeah. So a hammer toe is just a curled toe. It's when your toe is bent, kind of like you bend your finger. Yeah. Your toes will bend that way. They should be straight. When they have a little bit of a curl to them, that's a hammer toe. I'm not quite sure where we got the term hammer toe.
Yeah, because
maybe you hit it with a hammer to straighten it out. I don't know where it came from.
You know, they may have done that back in the day. I wouldn't be surprised. And it usually is not the big toe, it's the other toes.
It's the small toes, yes.
Okay, so what do you do? What's the most effective way to treat that?
Well, first thing you got to figure out what's causing the hammer toe and what kind of hammer toe it is. So there's flexible hammer toes, and then there's rigid hammer toes. A flexible hammer toe is one you can grab and you can straighten out. A rigid hammer toe is one where it's really arthritic and it's locked in that position, you can't move it. The rigid one, obviously, you've had longer than the flexible. So for a flexible hammer toe, frequently I've been, well, let me back up. So with hammer toes, you have to typically cut out the bone, rebalance the tendons, and straighten the toe. We use pins or implants in the toes to hold them straight. with a flexible hammer toe, sometimes you have some leeway as to what you can do. And I've been doing a procedure for the past several years that's what we call percutaneous, which means I do it in the office, I use a needle, and I actually go in and just rebalance the tendons. So I cut the tendon that's causing the deforming force that's causing the toe to bend down, which straightens the toe, allows the other tendons to come in and be stronger. So we have tendons on the bottom. Tendons connect muscle to bone. We have tendons on the bottom and on the top of the toes and the fingers. That's how we straighten and bend them. So typically it's the tendon on the bottom that's pulling too tightly, and you can make a tiny stick in the middle with a small needle and sever that tendon. It kind of frays, and it lengthens it, then it'll scar back in a lengthened position and the toe straight.
And it's minimally invasive. That's why part of this is so attractive, right?
Yeah, it's a great procedure because it's literally a needle stick, just like drawing blood. I put a Band-Aid on it, a little bit of a bandage if it bleeds, stick them into their regular shoe, and send them on their way, and just tell them to take a few days of taking it easy, and it heals up wonderfully well.
Wow. So now you have a YouTube channel. There's a video of this on there?
Yeah, so we do have a YouTube channel. I've had it for years. We've got videos of different conditions, educating people on exactly what you're asking, what a hammer toe is, what different conditions are, and we put procedures on there. So a few years ago I put a procedure doing this flexor tenotomy is what it's called. It's straightening a hammer toe, and it's been wildly successful.
You said you had a lady come from Peru.
Yeah, we get people from all over the country, and we recently had a lady from Peru call us. She worked for the U.S. Embassy in Peru and was coming here for training and said, hey, as long as I'm coming, let me get my toe fixed.
Yeah.
And we actually did toes on both feet. She did wonderfully well, and she's contacted us about having some other work done in the future when she comes back. So yeah, and that's because I do it in Spanish and English.
Right.
I speak both languages, so I put the videos in both languages, and we literally get calls and emails from all over the country and all over the world.
I'm sure. Okay, very good. How do we find that YouTube channel?
It's, if you type in Newhouse Foot and Ankle or just Newhouse Foot Doctor, it'll come up.
Okay.
Yeah, it's pretty easy to find on YouTube.
Easy enough. Let's jump back to the lines. Ellie is on the line. Ellie, good evening. What's your question?
Hi there.
Hi.
I have knots in the arch of my feet, and it started out in one foot, and then a couple of years later it came in the other foot. So they're in both feet, and I was curious to I was told it was probably a torn muscle.
So I guess I'd ask, is it a hard knot or a soft knot?
It's hard.
Okay.
They're hard.
And is it right below the skin in the arch?
Yes.
Yeah. So that is most likely what we call a plantar fibroma. A plantar fibroma is scar tissue that forms within the plantar fascia. Again, the plantar fascia is the big ligament that connects the heel to the toes, and if you pull up on your big toe, you can put your finger on the arch and you'll feel this hard structure, a band of tissue that forms when you pull the big toe up. That's called the plantar fascia, and these little knots will form in that edge. It's the medial edge of the plantar fascia, and what that is, it's scar tissue. So at some point you had a tear in the plantar fascia and you had excessive scar tissue form. Now, the difficult thing with that problem is they're very difficult to treat. They frequently will not go away on their own, and they can recur if you surgically cut them out. So there's a healing problem with that ligament. It's a hard problem for us to treat. It really is.
Why is that ligament so problematic? Is it just because we use it with every single step?
Yep. Yep. It moves.
Well, I've been a runner, so I didn't know if I did it from running.
Probably, yeah, that's probably, but it can happen just walking. I mean, it's not necessarily a running injury. It happens to people of all ages and, you know, activity levels.
Okay. Ellie, sorry, I wish we had better news for you. Is there anything you would suggest for her to do if it's...
Yeah, I mean, sometimes I'll give people cortisone injections. I'll use alcohol injections. We can do orthotics. There's some different prescription creams that we use. There definitely are things that we can do for it. In some cases, I will surgically remove them, and they don't always come back, but they have a high likelihood of coming back. You have to be really careful with them.
Okay.
You don't jump to surgery with that problem.
Gotcha. Ellie, thank you for your call. Good luck.
Thank you. Bye.
All right. We also have Cheryl on the line. Cheryl, good evening. What's your question?
I got a question about my toe. It's dark. It's dark. And I'm trying to find out what could be causing that.
It's darker than the rest of your toes? Is that what you're saying?
my big toe. My toenail. On my toenail.
It's the toenail. So color changes in the toenail can be lots of different things. It could be if it's just dark and bruised looking purplish, that could just be a little bit of dry blood underneath the toenail that you stubbed your toe. And that takes a long time to clear out. You have to grow a new nail, which can take 6 to 12 months for that to clear up. It could be the start of toenail fungus, which is an infection in the nail and the nail bed. And that may never go away without treating it. That in those cases, the nail gets thick and not just discolored, but it'll thicken, and again, without treatment, that's not going to change.
Okay, so something that she should probably come in for just to take a look.
She would need to have that looked at to know what's causing it.
Okay. We also have Kay on the line. Hi, Kay. Good evening. What's your question?
Does Medicare still cover the inserts and the orthotic shoes if you are diabetic, and how much do they cost, along with the Medicare?
Yeah, I'm glad you asked that question, because this has been an issue for us for years. So Medicare has what's called the Therapeutic shoe program, and diabetic patients that qualify can get 1 pair of shoes and inserts per year, per calendar year, from January to December. What has happened with Medicare over the past 5 to 6 years is they've really become sticklers on auditing providers that supply shoes. And what they're looking for is, this program was abused for a long time, and they were spending lots and lots of money on shoes and inserts for people that didn't necessarily need it. The purpose of the program is to provide shoes for people that are at risk for an amputation or losing a part of the foot or a leg. And what happened was anybody that had diabetes was getting shoes. And that's the misconception, is people think they can get shoes because they have diabetes and they have Medicare. And that's simply not the case. There's a list that Medicare puts out that you have to meet the criteria before you qualify for shoes. And that is, you have to have poor circulation, you have to have a deformity, you have to have a callus or some sort of pre-ulcerative lesion, they call it. You have to have a risk factor for developing an amputation, and it may be a prior amputation. There's a very strict list, and if you don't meet that criteria, then you don't get the shoes. And Medicare started auditing doctors and the providers that would supply shoes. And now a lot of people just don't even supply them in the city. It's a hard thing. They don't want to deal with it. Yeah, Medicare's, they audit everything, and the paperwork has become very onerous. You need signatures from, everybody that has ever seen you, it seems like. Yeah. And it's just made it really difficult to even get the people that need the shoes, the shoes. So it's not that Medicare doesn't cover them anymore, but they're just really strict on making sure everybody is doing it the right way.
Do you accept Medicare?
We do.
Okay.
Yep.
Well, so it's good to know. So
how much are they if Medicare covers it?
Well, that's a good question. The Medicare will pay for the shoes, and if you have a secondary insurance, that will cover the rest of the cost. Medicare will pay for 80% of the cost of the shoes, and they have a set fee schedule that, honestly, it's been quite a while since we've done shoes in our office, so I don't remember. It's a couple $100. I think it's like $250, maybe even $300 for the shoes and inserts. But Medicare covers the majority of it, and if you have a secondary, they cover all of it.
Good deal.
If you have discoloration, if your feet have discoloration in the skin, and you've already been through felt like you were walking on grate period.
Would that be one of the pre-existing or the qualifications? Is that what you're asking?
Yeah.
Okay.
No, actually that doesn't. If you have neuropathy, which is nerve damage, that doesn't necessarily mean you qualify for shoes. If you don't have a deformity, if you don't have a callus, if you don't have something that could lead to you losing a toe, you just have some numbness, that alone in and of itself does not qualify you for the shoes.
Okay. All right. Well, thank you.
Thank you for calling in. I feel like we got a lot of information out there. I appreciate that phone call. We have to take another quick break, but Sally Ann and Lisa, I know you're on the line. As soon as we come back, we'll take those calls. Stay with us.